I just want to welcome you. I'm Dr. Pam Schaff. I'm the director of the HEAL program, and this Lunch and Learn series is a way for us to invite scholars from the arts, humanities, and social sciences to come and talk with us about topics that intersect with our mission to have healthy individuals, communities, and societies. So it's my pleasure today to welcome Professor Peter Redfield, who is professor and chair of anthropology and Erburu chair in ethics, globalization, and development at USC. Dr. Redfield trained at Harvard and Berkeley, and he subsequently held postdoctoral appointments at UCLA and Johns Hopkins in history of science, technology, and medicine. Before coming to USC in 2020, he was professor of anthropology with a secondary appointment in social medicine at the University of North Carolina at Chapel Hill. The author of Life in Crisis, The Ethical Journey of Doctors Without Borders, and Space in the Tropics, From Convicts to Rockets in French Guiana. He is also co-editor of Forces of Compassion, Humanitarianism Between Ethics and Politics. His current research continues to focus on ethical issues in global health and humanitarianism, including efforts to redesign water and sanitation. He's held fellowships at the School for Advanced Research in Santa Fe and the Institute for Advanced Study at Princeton, in addition to serving as president of the Society for Cultural Anthropology. Today, he's going to talk with us about Doctors Without Borders, and I am pleased to welcome him, and thank you for being here.
First, I'd like to thank Dr. Schaff and the program for the invitation to speak with you. I've only been at USC for a few years, and I'm mostly at the other campus, and so every time I venture here, it's a bit of an adventure, actually. It's the term that I would use. But it's a pleasure to see all of you. I thought I would say one or two things before starting. First, that this won't be a particularly happy talk or a happy topic, and so I just wanted to alert you to that fact. I think it's about things which are important, and I'm assuming that this is a medical audience and that you're used to all kinds of unhappiness in the world and addressing it and responding to it. But it is your lunch hour, and in respect of that, I just wanted to give you that warning. I also wanted to say that this is work, a lot of the research I did for this project took place about 20 years ago, 15, 20 years ago. So some of the slides I'll be showing you, the statistics are out of date. I didn't have time to really go through and update everything. But basically the story is everything is still the same, only there's more. So you can see trend lines, I'll point to those, but the bottom line, the basic story is not that in flux. And that's part of what I want to convey to you in speaking about humanitarian medicine, in that it's a world that is full of sadly predictable issues, dilemmas, and crises, many of which can be foretold in advance, and it's fairly clear what will happen. And organizations like the one I'll talk about today, Doctors Without Borders, Médecins Sans Frontières, they exist essentially as a kind of global janitorial service responding to these problems of the world. So with those two caveats, I think I can go ahead and begin. Thank you for being here, especially those of you who are in the zone of contagion in the front. It's quite fascinating to see how well trained you are in public health to stay as far away as possible from anything that might be contagious. For today, there are a number of topics I could address. And I have about 40 slides, and I'll try and speak for about 45 minutes or so. Please, if there's something that is unclear, I'm perfectly happy to have an exchange with you, either while going through, especially those of you who dare to be in the front, but even those of you who are in the back, and answer any questions you might have at the end of the presentation or afterwards. I thought I would talk about medical selection today as a theme, and the formal sense of selection according to medical rationale, medical rationalities, that is triage. And Some of you may be quite familiar with these. Some of you may have been put into situations where you've had to practice something like this. I hope for many of you, you're not put in situations where you have to address the really extreme versions of this. But if nothing else, I thought that I could make this available to you and also reference this because there are a lot of things going on in the world currently where it's very clear that there are forms of selection going on in terms of whose lives matter more and whose lives matters less when it comes both to political action and then also to medical access and intervention. And what I'll be presenting to you today is how complicated and difficult it is, even for an organization which is seeking to be inclusive and to provide access and value all lives, how difficult it is to put that into practice. So I'm starting with a simple question: how does medical selection operate at a global scale? And in providing an answer, because I'm trained in anthropology, I like to look at particular anthropology and history. I like to look at particular cases and examples and follow them through in some detail through time. As opposed to doing a statistical analysis, I'm interested in forms of experience that are embodied, situated, and historical. That is what most of us call life, rather than a formalization of life and an abstraction of life. And so this organization, MSF, is for me a case study of what non-governmental politics look like, in that it's a very well-known transnational NGO at this point. It has a history. The term, if you're familiar with the term NGO, non-governmental organization, that also has a history, came into being with the founding of the United Nations after the Second World War to describe all those entities and actors who are not states, and therefore could not be a member of the United Nations as a nation state, but could, if you were an NGO, potentially have the capacity to speak in an organizational sense. And so what's interesting about MSF is and I'll be calling this organization MSF for the most part because that's how they're known in the aid world, by their acronyms. The aid world and global health in general and medicine, as I'm sure many of you have experienced, is just full of acronyms. That's the native language that people are speaking and using. And so the native term in this sense is MSF. It's a true NGO, as I'll try to explain to you, in that it's largely independently funded. It has no authorization other than its own self-authorization. It's essentially a collection of people who have come together historically in order to try and further the goal of practicing medicine without borders. That is, seeking to provide medical care to anyone and anywhere in the world. It was founded in 1971. There's a lot of history about why it came into being, essentially in the aftermath of the Nigerian civil war and the founding of Bangladesh, a couple of crises at that moment, which motivated a number of young, not all young, but mostly young, idealistic individuals who were French and who were trained in medicine to seek another path to intervene in the world and try and make it a better place. And they thought that the Red Cross, the International Committee of the Red Cross, which is a 19th century organization that a number of them have been working for, they thought it was old-fashioned and out of date, and they needed to start something new. By this point, MSF is very well established and large, as I will be indicating, and it's been around for over 50 years. So at this point, it's everything that it raged against in 1971. But the ethos, the sensibility of the organization has been that of being oppositional, young, essentially the teenager who would try and make noise and object to things in the world that seemed to be wrong. I should also say, because I'm going to be focused on things that are would be classified as crises and emergency, that a lot of the projects that MSF does are not ones which are as extreme as what I'll be referencing today, and not ones that even fit into the categorization of emergency. They've done a lot of work in a variety of maternal and child health. For example, HIV/AIDS care, they're one of the actors that rolled out antiretrovirals globally. So there are lots of pieces of the story that I'm not emphasizing here. But their logic and their history comes out of the history of emergency medicine. And that's part of the background which I'll be trying to convey to you. And what's interesting to me and what makes it valuable for this discussion of trying to think about medical selection is their focus is on saving lives. This is the ethical principle that saving lives is a good thing to do. Whatever else, whatever, we're not sure about the state of the world, very complicated, but saving lives is a good thing to do. Now, saving lives also has a history. There's different understandings of what that term would mean. Some of it historically is tied up also with missionary medicine and Christianity. And as a large organized religion, a salvational religion, the conception that you might save souls, which then gets transposed into the notion of saving bodies in terms of providing medical care. At present, you'll find saving lives justifies all kinds of things. People use it and reference it constantly as a kind of secular value, ethical value of what is good. And here I'm just quoting a famous work from the middle of the 20th century that makes this case that in the contemporary world we live in, the notion of saving lives is often the thing that people point to as being most aspirational, the best thing you could possibly do. It may have motivated some of you to study healthcare or go into medicine. But of course, the question then becomes, whose lives do you save? And when and where? And do some lives get saved more frequently than others? And who determines what it would mean to prioritize one life over another? Since you can justify all kinds of things in the name of saving lives. You can torture people in the name of saving lives, saving innocent lives, and so you torture someone you see as being potentially dangerous. You can bomb people. You can do all kinds of things in the name of saving lives. And you'll find it, if you start looking and paying attention, you'll find it all over the place. For humanitarian actors like MSF, what they're seeking to do is pursue a principle of equality in a world that's obviously unequal. In that, as everyone sitting here, I think is, if you stop and reflect for 1 second, and probably in experience you know this as well, some problems in the world get a lot more media attention than other problems. Some suffering gets a lot more attention than other suffering. And some lives are valued at a much higher rate than other lives. And you can see this very exactly in things like dollar amounts when you look at compensation for injury, and when you look in insurance regimes, and when you look at things like negotiation for ransom. If you're kidnapped, if any of you happen to be kidnapped, what is your value? What is your worth? Your kidnapper will have an idea of what the price tag is for your life, and certain lives are worth more than others. I'm trying to say it in a humorous way in order to also make you remember this point, because it's quite clear. For actors who are willing to do that, they have no doubt about who is worth more and who is worth less. So how do you select? How do you prioritize? And there's a tradition in healthcare of selecting according to medical principles and according to medical logic. And it's an evolving medical practice. The canonical history, you can find other histories to tell, but the canonical history, the one I'll just give you today for our purposes, is it emerges in the Napoleonic era of European warfare, in battlefield medicine, and when military medicine is coming into being as a particular kind of specialty and formalization. Then goes on, it gets standardized during the First World War. So every major military has a healthcare service, has a military corps, has a medical corps, and that medical corps is practicing a form of triage. And post-World War II, it becomes naturalized in a way that all of us are familiar with from endless TV shows and so on, in the emergency room, which gets invented as the site where emergency care will take place. And the very, very shorthand history of emergency medicine is it comes out of military medicine. A lot of the logics are very similar. You act very quickly, fast, prioritization, stabilization. and moving someone on. And you will encounter a wide range of problems. So what is triage in this setting? What is the core logic of it? It's that you should prioritize, all of you are sitting in the waiting room, my job, if I'm practicing triage, is to try and figure out who of you needs to be seen first according to your injury state, according to your medical condition, not anything else. Health status rather than your social criteria. So according to triage, it should not be whether or not you could pay. It should not be whether or not I know you. It shouldn't be whether or not I like you or I think that you're a good person. It should be none of those things. It should simply be my professional evaluation of your medical condition. So triage is a place where you see the exercise of independent medical judgment, which makes it quite interesting for thinking about ethics and the application of ethics in healthcare. Quickly, in terms of the conceptual framework of triage, again, it's a professional evaluation of bodily states. It's also an ethics which is very much centered around action. Triage is when people have to make decisions quickly. And ideally, you have a protocol in place. This is why you would have a triage protocol, which is already there so that you can follow rules rather than having to have a debate yourself over what would be the best course of action. This is the logic behind it. And the focus is very much on trying to save lives under most triage regimes. That is the goal. Not making it easier for people to die, which is another kind of care and health rationality. That you can try and ease someone's passage into death. That's not the focus of triage biomedically. It's very like a lot of biomedicine, that is contemporary modern medicine, the sort you're being trained at a school like Keck. A lot of its focus is on life and preserving life. It's not thinking that much in depth about the end of life. And they're also in triage, the focus is not on individual patients, but on a collective outcome. You're trying to, it's a very utilitarian framework in the formal ethical sense, consequentialist utilitarian framework. You're trying to produce the greatest good for the greatest number. It's not your individual patient who you're trying to save. Now, you may be familiar with the term triage and most major hospitals have a triage system that's in place in an emergency room and a category, a professional position of a triage nurse and so on, someone who would do intake and sort and figure out where people go. The hospital version of triage, and the one that we're more comfortable with, is the idea that all you have to do is wait, and eventually you'll be seen. And so it's just a question of how long you have to wait in the ER. And you may have to wait for a long, long time if you have a minor injury, but eventually you will be seen. The battlefield tradition of triage, however, is different. It's also the same for disasters. It's the one that if you're trained in disaster medicine or something, you'd encounter as well, which is very much that the assumption is that you may have limited resources. You may not be able to treat everyone. And so you are going to very quickly try and figure out who is salvageable. Who are the people you can save? And people you don't think you can save or would take too much time and energy to save, you don't. You don't focus on them. You focus on the cases of the people where you think you can maximize your resources to the greatest extent. Again, that's the kind of utilitarian ethical logic that's dominant. So if you're thinking about this formally, and there are various things you can look, if you're interested in triage, you can look this up. You can find various theories and ideas about it. But basically, it kicks in typically when there's a condition of scarcity, when you have someone who is trained in healthcare and therefore it has the standing to exercise professional judgment. And it involves an established system of prioritization. Also, this came up during the pandemic. There were lots. This is one of the moments where triage became more visible again in settings like the United States and many wealthy countries, where it's not as familiar to people who are living there as it is in more in settings where you have fewer resources to be able to distribute across the population. The other thing that's important to note about triage is it also often involves the suspension of other ethical norms in the name of health. That health becomes the dominant criterion that you're operating with, again, because it's the bodily condition, and it becomes the thing that you're focused on. And people have many ethical feelings about many values in life. Health is not the only one. But when you're in a setting where triage is dominant, that's the one that takes priority. So what I'm trying to suggest to you is that triage is a complicated site for thinking about ethics and thinking about choices and prioritization in a medical context. And this is especially true if you start looking globally, in that these are some of the elements that are operative in triage, that you're frequently dealing with scarcity, sometimes dire scarcity. If you're in a disaster zone or a war zone, you may have quite limited resources. Your stock of medicines may be running out, etc. It can be seen as something that's exceptional. This is the way that battlefield triage, disaster triage is usually seen. It's not business as usual. It's an exceptional moment. It's not what you want to be doing, as opposed to, again, what's dominant in a hospital, which is the need to sort, the everyday need to sort and prioritize, which any medical system needs to do. The focus, again, is frequently on survival, not on flourishing. So you may help people live, but it doesn't necessarily mean they will live a happy life. It just means you're prolonging their survival for a certain period of time. And classically in triage, the idea is there should be no other principle of usefulness, of utility that you're thinking about beyond survival. That's the only one that you should be focused on. But if you look at military history, it's not quite so simple, because sometimes triage systems have also had the goal of trying to return soldiers to a condition where they can go back to the front lines and fight again. That's one of the debates in terms of military history. Is that part of what you're trying to do in a medical service, is patch people up enough that they can again be effective in a particular kind of endeavor, which has nothing to do with survival. Indeed, it might be the complete opposite. So this is just a reference to Napoleon's chief surgeon, who's the one who usually gets the credit for being who framed some of the rationale of triage initially. Triage meaning picking or sorting. That's the logic of it linguistically. That the focus is on making sure that you save people who could be saved, that you're not ignoring. If you did first come, first serve without thinking about their medical condition, there might be people who would die while waiting. And so you need to find them and work on them first. That's essentially what he's talking about. So moving back to MSF and Doctors Without Borders, if you're a humanitarian actor and you're operating under a categorical moral logic, which is all lives are good, all lives are important. No one should die from stupid things. That's a saying that people in the humanitarian end of the aid world like to reference sometimes. That if there are people dying of stupid things, that's when you should act. If there are obvious things that could be fixed, that could be cured, that you need to do something. And you should do that equally across the board for all lives. In the case of MSF, they're operating in an expansive space. They're trying to work sans frontières, without borders, everywhere in the world, potentially, without regard to the impediments which might make it difficult to work there. Of course, that's an idealistic position as opposed to a realistic one. There are places it's much easier to work as a humanitarian healthcare provider than others. And again, these are some of the reasons why I think it's a particularly revealing case. It's transnational, it's quite large and established now, it's relatively independent, and it articulates its views frequently by speaking out through outrage, as opposed to the Red Cross tradition, which is one of maintaining neutral silence as much as possible in order to be able to negotiate with, in a war zone between warring parties, without making the headlines in order to maintain access and try and achieve the best result. MSF went in the other direction, and not quite as much as the myth goes. There's more similarity between these organizations than I just referenced in practice. But for our purposes today, one of the things that makes MSF very valuable and useful is they call out the state of the world periodically. And they will do things like they will publish lists of crises that are not getting enough attention as they see it in the media. That they're, if you followed the US news only, you would be aware of 2 wars going on in the world. But there are many more than that. There are lots of things going on, and there are lots of problems in the world. And if you start looking and digging, you can find them beneath the surface of the top line of media in a setting like this. And MSF does that. It's a way in which it's trying to map the suffering of the world fairly precisely through a medical evaluation. In that sense, it's practicing constantly a form of triage, I would suggest, or an organizational level. At the same time, every humanitarian actor encounters an ongoing anxiety in that there's always more need than you have capacity to meet. And here, this is just a passage from a famous memoir of the guy who's the inspiration for the Red Cross in the middle of the 19th century, Henri Dunant, where he's just a businessman who wanders in the aftermath of a battle and he's trying to help people. This is how the Red Cross gets started. And he realizes he could turn left and he would work with some people there, or he could turn right and he'd work with other people there. It's totally arbitrary which way he goes. There's need on either side. Which way do you turn? That's a constant dilemma. And MSF is constantly having to decide whether to turn left or to turn right. At the same time, they reject that need. That is, in terms of their rhetoric, in terms of their ideals, in terms of their values in the world, they think that it's wrong, that there should constantly be a lack of resources. They think it's wrong that there constantly are people who are suffering, particularly from things that could easily be fixed or were created by other humans in the first place. And so they have a complicated relationship to politics in that they see themselves as operating in response to political problems and political dilemmas, but they cannot solve political problems with healthcare. And they're acutely aware of that. So it's anti-utilitarian. Their goal is to save every life. They don't want to have to practice selection. They don't want to have to practice triage, even as they are constantly doing it. They refuse political rationales, even at the same time as they denounce a lot of political actors that they see as being nefarious. And they have an ambition to practice waiting room triage rather than battlefield triage, even though the reality of what they're doing is much more the battlefield. And the image I've been showing you for some time now is from their first ad campaign in the 1970s in France, and saying that in their waiting room there are 2 billion people. The population of the world was smaller in the 1970s. So the notion being that everyone is potentially in their waiting room. And so at the same time, they have realist problems of limits. They have this anxiety, do you turn left or do you turn right? And they're frequently having to practice choice at a population level. That is, choosing to work in this town versus that town, choosing to work with this group versus that group, simply because there are not enough resources to go around. They have principles when they do this of both seeking to be, to a certain degree, neutral. They have a very complicated relationship with neutrality, but absolutely to be impartial. And neutrality and partiality don't always line up. I can say more about that later if it's clear. But if you stop and think about it for a second, if you have 1,000 here and 10 here, if you're being impartial, it's 1,010. But that doesn't appear neutral if people are looking at it and saying you're spending much more time over here than you are over there. So there's constantly a tension between some of the different principles that people in the humanitarian world seek to pursue. So where are they working? Here, I'll just quickly try and I've tried to sketch out a bit of the ethics and the terrain of the logic of selection that they're operating with. And now I'll try and give you some social facts so you have a sense of where things stand. So Excuse me. On the left is an image from 2004, and on the right, the one that I just added from 2022, their annual report. As you'll note, there's a little bit of change between the map of their operation, but not a lot. There's a lot of constancy in terms of where they're working and where they are focused in the world. And this is just weighting and adding weight to it in terms of where the expenditure of their resources primarily occurs. Sorry, the one on the right, they did a different graphic for this. And so the numbers here are quite small, but some of you probably have good eyesight. You're young and you can see this acutely at a distance. But the numbers underneath give you a sense of how much financially they are investing in resources in different segments of the world, divided by classical continents. Their budget has gone up continuously since their founding, since they started to emphasize private fundraising. When I first made the slide, the last data I had was in 2008, but I just added this here. Their current, for the whole organization, they're a complicated organization. That's just a footnote. I can tell you more if you like to know, but for the whole organization combined, their budget in 2022 was 2.25 billion euro. So it's not small. It's not modest. It's quite a lot of money. There are fluctuations in terms of things, and this right here is that little bump where income went up over expenditure briefly, because they try to expend all the money that's coming in constantly, was the 2005 tsunami, Indian Ocean tsunami, which was a fundraising bonanza, in terms of the history of fundraising, one of the big moments. In terms of organizational scale, this is all out of date, but so the numbers are much bigger with all of them. And some of the sequences changed a little bit, but MSF is the one in red, and here are some other well-known organizations to give you a sense of relative scale and size for those of you who have any sense or any interest in terms of thinking about the wider world of international aid. One thing I would just note is that bilateral humanitarian aid, that it's aid, government-to-government aid that's classified that way, which may or may not actually be paid out, is frequently promised, but whether it actually arrives is another question. That's at a different scale than all the work of NGOs in the world and smaller organizations. There are many problems which, in order to respond to them, it really is a question of state action and expenditure at the level of state budgets. I also, whenever talking about humanitarianism, I want to emphasize that because people have lots of questions and debates and frequently around money, people can be critical about how money flows and so on. It's important to put it into perspective that all of humanitarian spending and all of aid spending is a tiny fraction of what is spent on military preparedness and military action globally. There's much, much more money going to death than going to team life, if you're thinking about it that way. Team death is reliable and winning the numbers game always. MSF decided at the end of the 1990s, when they won the Nobel Prize, that they were going to emphasize independent fundraising and try and pull away from any governmental sources so that they have greater independence of action. They can make their own decisions. And so they emphasized as much as possible small-scale fundraising, a lot of it from private individuals like us. And they've been very, very successful with it. Again, like 97% of their budget is coming from one way or another private sources. And this echoes the fact that for them, independence is an extremely important value. They want to be able to act independently. They want to be able to speak and respond and make decisions as they see fit in the name of healthcare. Again, which echoes the triage tradition. Of course, in practice, all this is qualified in that as media focus shifts, donor priorities shift. People will give money for certain causes more than they will give money to other causes. And there are lots of studies in social psychology which can tell you something about fundraising, the way that people respond to different kinds of images and different kinds of problems. People tend to give more money to photogenic individuals than they do to statistical arguments. And they tend to give money to situations where they think it's going to be short term and they can make a difference and something can be solved quickly. It's much harder to get people to pay money on an ongoing basis to something like to respond to something like an endemic disease. So in terms of their operations, just to give you a sense of what's going on, what are the kinds of procedures that this organization is involved in. This is from 2010, so a bit out of date. It's just more now, but to give you this is globally what they are up to. And by point of comparison, because I was at Chapel Hill for a long time, I decided to look at the numbers for 2010 at UNC Hospital in Chapel Hill, which is a major university hospital, a big tertiary care. It also serves as a county hospital, is serving multiple functions. And to do a comparison, because this is revealing about a number of things in terms of medical care, including the cost per patient and the cost per procedure in the United States, as opposed to many other parts of the world. Because the budget at that time in 2010 for UNC Hospital and the budget for MSF were roughly the same, about $1 billion a year at that time. And so if you're looking purely at outputs and you're thinking just in terms of lives saved, it's pretty clear where the maximization is. And it's also clear that there's certain things which are not frequently a problem in a place like North Carolina. Malaria is not something you commonly see in Chapel Hill, whereas it's a big problem in many parts of the world. Therapeutic feeding of under 5 children, etc. So now I'll just quickly give you some statements that come from different practitioners in MSF at different moments in time, where they're speaking about logics of selection and different kinds of pressures that they feel in terms of making decisions. One is they want to preserve not just their independence, but also their flexibility. They don't want to be running only one hospital in one part of the world, which they could do. But they do not see that as being appropriate. Their vision is very much still, in this sense, a kind of European vision of the 1970s. Their vision is that every nation state should have a Ministry of Health, and that Ministry of Health should serve its people, and it should run a hospital for the benefit of the population. It's the World Health Organization kind of vision of post-World War II, of how healthcare would be provided to people. So they want to be ready to be able to move and shift and go to different parts of the world. They see themselves as a mobile organization, not one that's fixed, which creates a whole set of ethical tensions around the question of when do you stop a project and when do you leave. At the same time, they also have a desire to be doing things, and they have a tendency to act, sometimes to act perhaps too quickly, to rush in and do the same way that if you're trained in emergency medicine, it's all go, go, go. You think you should be doing something immediately. And not all of healthcare, not all problems necessarily lend themselves to quick action. Again, it's particular kinds of settings, particular kinds of procedure. But their bias tends to be towards action. For those people who are, because again, it's a big distributed transnational organization, for those people who are sitting in operational centers, they're looking at many different projects at the same time, and they're trying to compare and evaluate the degree to which they should be emphasizing one versus another. So selection is going on in that sense centrally, not just at the point of care in projects on the ground. And they have to be thinking not only that there's not just one crisis in the world, and that there can be multiple forms of suffering. And they may want to attend to several of them at once. This is the logic that's through a lot of argument and debate internally in the organization, which is constant and ongoing. This is the logic that they pursue. Um, and then this is an example of someone who was remembering a moment in another period of high tension from the 1990s, ancient history now, but not all that different from some things going on in the world today. In Chechnya, where you had a lot of aerial bombing of civilian populations, this is a setting where this particular individual, she had to practice triage, and it was deeply troubling to her in terms of her memory. It was something that marked her, and it was something that she would not forget in life. And for most people who've been in situations where they've had to make very difficult choices, that choice stays with you. It burdens you to some extent, and that's something that you need to learn to live with if you're going to pursue a career in healthcare just in general, but also, and especially if you're going to be doing it in humanitarian settings. And the thing which I just wanted to emphasize here is that it's difficult sometimes to admit or accept the fact that you might bear some responsibility for a choice. That tends to make people very uncomfortable, the idea, especially a choice about life or death, that you might be the one who's evaluating that. And the stakes attached to making that decision. Then, of course, there are perspectives. That something that can seem terrible to some people in one setting may seem less terrible to someone else who's been in another location and seen another crisis or has a sense of a field of comparison. And in general, this is one of the things that is also a struggle for an organization like MSF, is for people who've been doing it for a period of time to be able to move between different settings and recognize both commonality of suffering while at the same time not obscuring difference in suffering. There was, I just mentioned, there was, northern Uganda was a conflict zone in the beginning of the 2000s, something that probably a few of you may know in this room, but may have been forgotten. And so that's the point of comparison that's being used. There was a low intensity form of war that was going on there. And then there is the question, if you have a strong ethical attachment to the value of life, the question is, how do you give up on people's lives? And so this is a constant ongoing dilemma for anybody who's going to be running humanitarian projects, especially ones that touch on extreme situations and conditions. Here again, I just remind you that life is frequently the thing that gets pointed to as being a highest value at present. When people want to try and convince someone else who values life that a particular course of action is good, this is again the thing that many people will point to. So this is just a tongue-in-cheek formula. It is a kind of distillation of what's going on, that MSF is operating in response to crisis, and the tension points which determine a lot of their decision-making are the combination of independence. So they have to decide, they have to claim the decision, but at the same time, their sense of a need for mobility. So they, again, are led constantly back to a problem of triage. And then I thought I would just include this as a reminder that there are different rationales beyond medicine, and there are times when people who are trying to provide care for a population will encounter, for another group of people, this is where anthropology kicks in, they may find out that there are different values at play. And this is an example, this is a well-known influential figure in MSF speaking in 2001 about a famine in northern Uganda in an area called Karamoja in 1980, where one of the things, it was the first response to malnutrition that MSF had ever tried to mount at that time. They were a very small organization. And what they found, which shocked them, is they thought they were going to save those who are most at risk medically, which is children under 5, if you're in a famine setting, which is usually a political problem, by the way. It's not really a healthcare problem, but the healthcare end of it, if you're dealing with malnutrition, it's children under 5 are the ones who are most likely to die in settings of food stress. But in this setting, what people really wanted to do was to prioritize elders. And the logic that they give in terms of an evaluation of life here, that elders are hard to grow. Elders take a long time. Children are replaceable. You can always have more children quickly. But elders take a long time. They're a deep investment for a group of people. And I'm mentioning that to you as just as a way, because in the United States, contemporary United States, there's no life more valuable or sacred than a child's life. Frequently, the innocent child is the one who's seen as being most valuable and is the best for fundraising. But that's not always the logic that everyone would necessarily maintain. In very difficult moments, it's not that they want to get rid of children, but in very difficult moments where you have to prioritize, people may make different decisions. So I just wanted to quickly end with giving you an outline of an argument that MSF's form of humanitarianism is all about an ethics of action, a medical ethics of action. Situations of emergency offer moral clarity, moments when lives really seem at risk. That's the moment when you know you have to do something, because if you wait and contemplate, you know what the outcome will be. And so there's an imperative to act. So these are settings of moral clarity. And if saving lives is your ethical emphasis, then it's clear what you have to try and do. But once it's beyond the situation of clear emergency, once it's beyond that moment of life-saving, or once it's a question of who you prioritize within it, then things become much less certain. And action has to acknowledge decision. And this is where, if you look etymologically, the Greek term crisis, and in Hippocratic medicine also, it's the moment in a fever, when a fever breaks and goes one way or another, and it's whether the patient will survive and live, whether the disease will pass, or whether it will return in a more intensified fashion, and the outcome might be death. And so this is the root from which we get crisis and our concept of what crisis might be. And it relates, again, to a question of choice, just like triage does. And so through the example of MSF, you encounter some of the limits of expert medical reason and decision-making and questions about accountability. And I'll just end with two things. This is a cartoon from MSF where they have a lot of cartoons, they have a lot of active internal debate and so on. And so she's asking, how do you do it in MSF? And he says, in MSF, we don't do it like that. No, not like that, not like that. She says, well, how do you do it? He says, not like that, but better. Do you have another question? This is sort of their internal dissatisfaction, which is constantly present, that they're not very happy with what they're doing, and yet at the same time, they're also doing it. And then the last line, which I'll leave you with, in case it's, and to fulfill my promise, this wouldn't necessarily be an uplifting talk, a line from somebody, a project coordinator in New York, who wanted people to know, especially people who might want to volunteer with an organization like MSF, that this is what you face. It doesn't mean you should stop acting. It just means that you have to recognize that it's not going to be a Hollywood ending all of the time. And so with that, I've reached an endpoint, and I'm happy to discuss anything else you'd like to discuss, or you can rush off to your next appointment.